All right, why don't we go ahead and get started? Good morning, everyone. Welcome to Pediatric Grand Rounds. I'm Lisa Chamberlain and happy to welcome you. As always, please text the code that you see here to the number to confirm your attendance and get CME. And if this flashes by too quickly, don't worry, it will be in the chat for the duration of the talk. Before we introduce Emily, I'd like to give you a heads up on some upcoming pediatric grand rounds. We'll be hearing about clinical challenges of Kawasaki's disease with some thoughts on COVID coming from Dr. McCrindle from the University of Toronto next week. That will be followed the following Friday by a conversation around pediatric medical device innovation, not just about kids being little adults. So that'll come from Dr. Fuerch and Wall from here at Stanford. So lots to look forward to. Next slide, please. I want to make sure everyone's aware of our COVID-19 Children's Seminar Series. It's a great series of talks led by Dr. Schroeder. And next we'll be hearing from Drs. Maldonado and Matthew on March 11th. That's on Thursdays from 12 to 1. So please do zoom in for that. There'll be lots of, I'm sure, great updates about both vaccinations in children and the trial that Stanford will be participating in. So please do zoom in for that. Next slide. Finally, we just want to let everyone know and be reminded that our 12th annual Pediatric Research Retreat will be a virtual event this year, 3 days, 3 half days on Monday, April 19th, Wednesday, the 21st, and Thursday, the 22nd. So please do put that on your calendar. And for a quick look at some of the speakers they have teed up. Next slide. It looks like a great series of talks, everything ranging from some of our trainees to our most senior faculty sharing about their exciting work. So please do get those dates and times on your calendar. And with that, I would like to hand things over to Dr. Catherine Aftendilian, who will be introducing our Grand Round speaker this morning.
Thanks, Lisa. I'm very happy and excited to introduce Emily Johnston, who is an assistant professor in Heme-Onc at the University of Alabama. Emily spent a lot of time with us at Stanford, getting her MD and completing her residency and fellowship training before making the move to Alabama. She has done some truly amazing work developing quality measures for end-of-life care for children with cancer and leveraging those measures to reduce disparities in end-of-life care. And then more recently, in addition to that work, she's been evaluating disparities in care for children with cancer and COVID-19. Stanford has actually contributed multiple patients to this report that she'll talk about. And I'm really excited to hear what she has to say. Take it away, Emily.
Thank you so much for that kind introduction, Dr. Aftendilian, and thank you, Dr. Chamberlain, for inviting me. It's a special honor to get to present to many of my former colleagues. I would usually give a shout out to all of those residents in the back left corner, but I don't know where they're watching from during the pandemic. So a shout out to you wherever you are. So today I'm excited to talk with you about COVID-19 in children with cancer, which is really a tale of disparities. I will talk about the formation of this registry and then the clinical course of COVID-19 in children with cancer, including what the risk factors are for getting COVID, as well as the risk factors for having a severe course. And I think there's some thought-provoking things here, and so I'll hopefully have plenty of time for some discussion at the end. So back recently, I've had an 18-year-old female with metastatic desmoplastic small round cell tumor, a tumor that has a poor prognosis to begin with. She probably has less than a 20% chance of long-term survival and has been going through treatment for over a year. She's gotten 13 cycles of chemotherapy, radiation, and surgery. We have 2 more cycles to go, so we're getting there. From her chemotherapy, she has also developed diabetes insipidus. She had a positive COVID contact and then developed cough, fever, abdominal pain, congestion, and was found to be COVID positive. And I had to figure out what to do with her. Should I admit her for observation? Should I delay her chemotherapy? It's hard to know. And I think many of you in the room have had experiences like this during the pandemic. What do you do with a kid on dialysis or who has heart failure, who tests positive for COVID? So we were not the only ones with this experience. Back in March of last year, oncologists in New York and New Jersey were starting to see more and more kids with cancer and COVID. So Dr. Levine from Cornell posted on Wolfpack Pups, which is a Facebook group for females in pediatric hematology oncology, and said, does anyone know of formal efforts to document these cases? And Dr. Sharma and Stockman both responded. So be careful what you respond to on Facebook. So 7 of us at 6 institutions established the Pediatric COVID-19 Cancer Case Report, or POC report, with myself, Dr. Julie Wolfson, also at University of Alabama at Birmingham, and Dr. Levine taking the lead. Our goal was to capture the clinical experience of children with cancer and COVID-19 in order to inform clinical care real time. We didn't want all of this data to just go into a database that would sit there, but really wanted to make sure that we were helping the pediatric oncology community care for these patients during the ongoing pandemic. Therefore, we developed a survey that pediatric oncology providers would use to enter data about their children with cancer who had COVID-19. Their survey included information about their cancer diagnosis, such as what the diagnosis was, if they had relapsed, and their most recent cancer treatment, and their most recent complete blood count. The COVID-19 information included symptoms of COVID-19, support required due to the COVID-19 diagnosis, and any changes to cancer-directed therapy due to COVID-19. Sociodemographics included race, ethnicity, insurance, and age at time of COVID-19 diagnosis. We also included a 4 and 12-week follow-up so we could hopefully capture the full course of the COVID-19 infection. In order to facilitate rapid approval and uptake of the survey at different sites, we decided to design a survey with no personal health information to facilitate. We then phoned a lot of friends. So we posted back about the survey on Wolfpack Pups and every single other Facebook group that we could think that had anything to do with COVID-19 and children with cancer. We emailed every single children's oncology group site PI in the United States, and we phoned a lot of friends. With that, we were able to produce our first pediatric oncology COVID-19 case report on April 29th with a whole 12 cases and distributed that to the pediatric oncology community. Getting the registry up and running was a labor of love by many. And just to recap the timeline, we had that fateful Facebook conversation on March 23rd. We were able to submit to the University of Alabama at Birmingham IRB on April 1st, then had IRB approval by the 15th, had our first patient submitted on April 17th, and sent out the first POC report to the community on April 29th. I think we really were lucky in that we hit the IRB at a sweet spot when they were prioritizing COVID-19 studies, but were not yet overrun by COVID studies. Since that time, we have been sending out data briefs about the registry every 2 to 4 weeks to the pediatric oncology community. That report really has 3 purposes. First, it informs the pediatric oncology community about children with cancer and COVID to help guide clinical care during this challenging time. It also is a reminder for sites to submit their patients, and it is a huge opportunity to say thank you to all of the sites that are taking time to go through IRB process and enter patients without any compensation. So since April 29th, we have also been working hard on bringing on more and more sites. This has really been challenging because of all of the IRB and contract variations across the country. So this is data representing 75 sites. And in terms of their requirements for opening the study, which is the exact same across the country and requires no PHI, 44% of sites consider the registry exempt, 51% of sites considered it expedited, 5% required no local IRB approval, and 29% required a data use agreement, which of course means that 70% did not require a data use agreement. There were another 2 sites that really wanted to open the registry, but decided not to because their local IRBs were going to require individual consent from each patient that was entered into the registry. Additionally, since then, we have been having to make survey modifications. We designed this registry and survey back in April when we did not know much about COVID-19 and have clearly had to keep up. For example, we did not have abdominal pain listed as a symptom when we first started the survey, which has now been added. And clearly there have been a lot of changes in COVID-19 directed therapy. Currently, we have a modification in place to add monoclonal antibody therapy. At this point, we released our last report to the community last week, which included 747 children with cancer from 94 sites across the country. We also have another 21 sites that are in process of IRB approval. I'm now going to move into the clinical course of COVID-19 in children with cancer, so what we have learned from this data. But as I do that, I just want to take a moment to say that we have all lived through this pandemic, unfortunately. I also am not a COVID-19 or an infectious disease specialist, of which I am sure there are many in the audience. So I am really going to focus on COVID-19 in one population in particular, children with cancer. So at the end of December, we formally cut our data and have done in-depth cleaning to do more in-depth analysis than we can do with our regular biweekly reports. With that analysis, we wanted to ask several critical questions. First, how do children with cancer and COVID compare to the general pediatric oncology population? Second, what is the clinical course of children with cancer and COVID? And finally, which children with cancer and COVID are at risk of getting sick from their COVID? So we had asked sites to enter information on children who had gotten cancer-directed therapy in the last year. That could have been chemotherapy, radiation, transplant for a malignancy, or receiving ongoing graft versus host disease prophylaxis due to a transplant for malignancy. As of that point where we cut the data at the end of December, we had 651 patients in our database. The database did actually include patients 0 to 39 at the time of COVID-19 diagnosis, but for this analysis, we really wanted to focus on the pediatric population. So this includes 624 children who were 21 or younger at their time of COVID-19 diagnosis. There were also a handful of children that did not receive cancer-directed therapy in the last year. Instead, they had things like a cancer predisposition syndrome. So in the end, this analysis includes 614 children with cancer and COVID-19 who were diagnosed with their COVID in 2020. This shows where those 614 patients came from. So as you can see, we have pretty good distribution across the continental United States, other than missing that Mountain West area. And as you'd expect, the states with the most patients include you guys in California, Texas, and New York. And this is a very similar map that shows our the 84 participating sites as of the end of December. And the size of the dot represents the number of participating sites in that state. The blue is the sites that have submitted patients, and the purple, those that are participating but have no patients. And as you can see, this map is very similar to the previous map and shows that lack of sites participating in the Mountain West, although Utah is getting up on board, so we're excited for that. And what I think is really interesting about this is that even at the end of December, there were still pediatric oncology centers in the United States who did not have any COVID positive children with cancer, including here in California. And so who were these kids? So the median age at COVID-19 diagnosis was 11 years old. The majority, 58%, were male. And the largest racial ethnic group was Hispanic with 49%. And as I mentioned, one of the goals was to compare this population to the general pediatric oncology population, which we will do shortly. We also had 64% of our population that was publicly insured. And for diagnosis, 67% of our population had a hematologic malignancy like leukemia or lymphoma. And just going to take you back to your pediatric oncology rotation for a moment to remind you why we care so much about hematologic versus malignancies versus solid tumors. So kids with hematologic malignancies, as opposed to solid tumors, get very different treatment. Hematologic malignancy kids both have some abnormalities in their bone marrow to begin with, but then they also get more prolonged treatment that has prolonged periods of neutropenia and immunosuppression. Whereas kids with solid tumors get kind of a big wallop of chemo at the beginning of the month, have some immunosuppression after that, and then recover. So their periods of immunosuppression are shorter. So in general, kind of think about kids with hematologic malignancies as having more immunosuppression and being more vulnerable to infections. 19% of our registry had relapsed or refractory disease, and 38% had a comorbidity other than cancer. The most common single comorbidities were obesity in 10%, asthma in 5%, and trisomy 21 in 4%. 18% did have another comorbidity that did not reach those numbers and ranged tremendously from things like autism to diabetes insipidus. So going to that question of how the children with cancer and COVID compared to the general pediatric oncology population, we were able to pull information about the general pediatric oncology population from the Surveillance Epidemiology and In Results Program, or SEER data, which captures information from multiple state registries. And here for diagnosis, you can see that our study population had 67% of kids with a hematologic malignancy compared to only 38% of the general pediatric oncology population, which kind of supports what we just talked about in that kids with hematologic malignancies are more immunosuppressed and more vulnerable to infection, including COVID-19. And for insurance, 64% of our study population had public insurance compared to 34% of the pediatric oncology population. And this reflects a lot of what we've been learning about COVID-19 in the general population, in that people from lower income areas are more likely to get COVID-19 infection. And with race ethnicity, 49% of our study population is Hispanic compared to 30% of the pediatric oncology population. So again, in our study population, it's mirroring the general COVID experience with increased burden of COVID-19 in underrepresented minorities. However, what is interesting about our population is that we have 11% Black patients in our population compared to 10% of Blacks in the general pediatric oncology population. So don't see that same disparity that is seen in Blacks in the general COVID population. To explore that a little bit more, we wanted to explore whether or not we just had a different population of Black patients and different SES than Hispanic patients. Because we do know, kind of thinking back to that map, we do have good representation from the Southern United States. So would have expected to have a large enough Black population to see overrepresentation if it should be there. So to tease apart the socioeconomics piece, we looked at rates of public insurance and private insurance within racial and ethnic groups. So here you can see that 78% of Black children had public insurance compared to 82% of Hispanic children, but 42% of white children. So in our population, both Black and Hispanic children were more likely to have public insurance than white children, but Blacks and Hispanics had very similar rates of public insurance. So it seems like, so from a socioeconomic perspective, the Blacks and Hispanics in our population are similar. However, of course, we don't know who we don't have. Maybe the rest of the Blacks at the participating institutions who did not have COVID come from higher socioeconomic status, but this is kind of a piece of the picture. And so in addition to figuring out how our population compared to the general pediatric oncology population, I wanted to know what the typical course of COVID-19 in children with cancer was. So was the cough, fever, abdominal pain, and congestion for my patient typical for kids with cancer and COVID? And what would happen to her? Would she most likely end up in the hospital? What would happen? So 36% of kids with cancer in our population were asymptomatic from their COVID. As I expected, there was a higher percentage of patients with solid tumor who are asymptomatic, 44%, compared to those with hematologic malignancies, 32%. Again, going back to that idea that kids with hematologic malignancies have more immunosuppression than those with solid tumors. 46% of the population had a general systemic symptom such as fever or fatigue. 45% had a respiratory symptom such as cough, and 12% had gastrointestinal symptoms and 10% neurologic symptoms. We also did have 11 kids with MIS-C. And for kids who had symptoms, the median duration of symptoms was 5 days, ranging from 1 to 60 days. And how sick did they get? So 63% of the population did not require hospitalization, ICU admission, or any kind of respiratory support. And again, those kids with solid tumors were less likely to need support. So 72% of kids with solid tumors required support did not require support compared to 59% of those with hematologic malignancies. So again, those immunosuppressed kids with hematologic malignancies were more likely to get sicker. 33% of our kids with cancer were admitted to the hospital, 11% admitted to the ICU, and 13% required respiratory support. Of those who required respiratory support, 8% required oxygen, 2% required BiPAP, and 4% were intubated. Another 2% of our population required pressors, a handful required dialysis, and there was one child who required ECMO. So how does this compare to children with COVID-19 who do not have cancer? So Bailey published a study of over 100,000 children with cancer and COVID-19. And compared to their population, kids with cancer had 4.9 times higher rates of hospitalization than the general pediatric population. 33.2% of our population being admitted versus 6.7% of the general pediatric population. It is a little hard though to interpret exactly what this increased rate of hospitalization means in kids with cancer, because some kids with cancer and COVID were admitted for observation, particularly early on in the pandemic, when we didn't know if kids with cancer were more likely to get sick or what would happen. There's also been kids who were admitted for chemotherapy at programs who did not have the capacity to do outpatient chemotherapy for kids with COVID because of isolation requirements. So this increased rates of hospitalization in kids with cancer and COVID does not necessarily reflect a sicker cohort. However, most likely ICU admission criteria are more similar between patients with cancer and COVID and the general population. And kids in our cohort were 5.8 times more likely to be admitted to the ICU than kids in the general pediatric population. So 10.5% of our population was admitted to the ICU compared to 1.8% of the patients in the Bailey study. We also had 19 kids in our study who died. 6 of those were clearly due to cancer deaths. For instance, patients who had a COVID test when they enrolled on hospice, even though they were asymptomatic, tested positive for COVID and subsequently died on hospice. 5 really seemed to be a combination of cancer and COVID, and hard to tease the two out. For instance, a kid with metastasis to the lungs who has respiratory compromise at baseline tests positive for COVID and then ends up intubated and is not able to be extubated and subsequently die. Really seems to be an interaction between the COVID and the cancer. And then there were 8 kids who truly seemed to die of COVID alone. So how does this compare to the general pediatric population? So when only looking at the kids where COVID contributed to their cause of death, kids with cancer had 10 times higher rates of death due to COVID than the general pediatric population. So 2% in our cohort compared to 0.2% in the Bailey study. And if you only look at those 8 that died of just COVID, we had rates of death of 1.4% in our cohort compared to 0.2% in the Bailey cohort. So still 7 times higher rates of death. So what did we do about it? 17% of kids in our cohort got some kind of COVID-19 directed therapy. The most common COVID-19 directed therapies were immune modulatory. So things like anakinra, steroids, IVIG, and 8% of the kids in our cohort got immune modulatory therapy. 7% received remdesivir, and then there were also kids who received other treatments such as anticoagulation, monoclonal antibody, and yes, hydroxychloroquine. Unfortunately, since we don't have any PHI, we do not have date, so cannot tell how COVID-19 directed therapy has changed over the course of the pandemic. We hope that we're using less hydroxychloroquine now, but we can't figure that out with our data. And what is really important to pediatric oncologists and to kids with cancer and their families is what happened to cancer-directed therapy due to COVID. And again, going back to that your pediatric oncology rotations, you may or may not remember that cancer survival for kids with cancer has drastically improved in the last decades. That improvement is largely due to intensifying treatment. Therefore, holding or delaying chemotherapy and other cancer treatments can impact survival. Because of that, pediatric oncologists really don't like to change therapy without a good reason. So most usually changes in cancer therapy are protocol driven, like holding chemotherapy when the absolute neutrophil count is too low to safely give chemotherapy. We less commonly delay for non-protocol driven reasons, like we don't have the capacity to give chemo or a kid just looks sick. So in our population of kids who are getting active treatment, 44% of them had changes in cancer-directed therapy. So almost half of kids had a change in their oncology treatment. 10% had a protocol-driven reason, so chemotherapy delayed due to neutropenia, and 30% had non-protocol, more subjective reasons. And some of that could be due to uncertainty of the clinical course of COVID-19 in children with cancer, not wanting to give kids with an active infection chemotherapy that would suppress their immune system. Some kids could have been too sick to get chemotherapy, and there also could be system capacity issues like inability to give chemotherapy to COVID positive patients easily. 6% of our population did have other delays in treatment, such as delays in transplant, radiation, and scans. And as a note, these delays were real. It wasn't that a child was supposed to get admitted for chemotherapy on Tuesday and got admitted for on Wednesday instead. But the delay in therapy was more than 2 weeks for 46% of kids. So almost half of those chemotherapy changes were for more than 2 weeks. And then going back to my patient, was she at risk of getting sick? So which kids with cancer are at risk of hospitalization, ICU admission, and those changes in cancer-directed therapy? So we constructed multivariable binomial regression models to evaluate the risk of getting sicker. And I'm going to show the results for cancer diagnosis, comorbidities, age at time of COVID-19 diagnosis, insurance, and race ethnicity one at a time. But they are all included in all of the models, as is whether or not a patient has gotten a transplant and their absolute neutrophil count at time of COVID-19 diagnosis. But I won't show those results today. Sorry, transplanters. So for each of these, we have relative risk along the left side, and what you're comparing it to, or the reference, has a relative risk of 1. I show the relative risk as well as the 95% confidence interval. So anything that doesn't cross that 1, that line, is significant at the P of 0.05 level. So here is cancer diagnosis with a reference of solid tumor. And you can see that kids with hematologic malignancies are more likely to be hospitalized, but not more likely to be admitted to the ICU or have changes in cancer-directed therapy. Again, going back to that idea that they are more immunosuppressed than kids with solid tumors, so more likely to get admitted to the hospital. And comorbidities with the reference of no comorbidities. So kids with comorbidities are more likely to be admitted to the hospital and admitted to the ICU, but not more likely to have changes in their cancer-directed therapy. And what I think is really interesting about this is remembering back, these comorbidities were a hodgepodge of things: trisomy 21, obesity, asthma. But even taken as a whole, kids with comorbidities were more likely to get sick from their COVID-19, which I think supports kind of what they've seen in adults, that if you're sick going into COVID-19, you're more likely to get sick from your COVID-19. And age with reference of less than 11 years. So kids 11 and older were more likely to be admitted to the ICU, but not more likely to be hospitalized or have changes in their cancer-directed therapy. And this older kids getting sick has also been found in general pediatric studies. And insurance with reference of private insurance. Interestingly, kids with public insurance are not more likely to be admitted to the hospital have an ICU admission, or have changes in their cancer-directed therapy, which is different than the general COVID experience in which people from lower income areas do tend to get sicker from their COVID-19. And race ethnicity. So Hispanic children with cancer and COVID are more likely to have changes in their cancer-directed therapy, but not more likely to be admitted to the hospital or to the ICU. So they are more likely to have their therapy changed, but are not actually getting sicker. But of a note, you'll see that the Black patients were not more likely to be hospitalized, have an ICU admission, or have changes in cancer-directed therapy. And because of how important changes in cancer-directed therapy are and the big implications that can have, we wanted to explore this a little bit further. We wanted to see whether or not these changes in cancer-directed therapy for Hispanic patients were protocol-driven, so due to things like neutropenia, or more subjectively driven and not due to neutropenia. And here you can see that Hispanic children were more likely to have changes in chemotherapy for both protocol-driven and subjective reasons, but that neither of those reached statistical significance. So it appears that some of those changes for Hispanic kids are protocol-driven and subjective. And definitely having these subjective changes as part of it is concerning because Hispanic children already have worse outcomes than other children with cancer for a number of cancers. And are these increased changes in cancer-directed therapy due to COVID going to worsen these existing survival disparities? What we don't know is why people were making these subjective changes. Is it because of a history of Hispanic children having worse side effects from cancer than non-Hispanic white children? Are there logistical issues of getting children with COVID to clinic since they usually have to have a non-COVID positive person bring them to clinic? Or is it driven by provider bias? It would not be the first time provider bias has impacted the care for Hispanic children with cancer. So this is a study of 357 children with cancer treated at 2 centers. It included surveys of parents and their clinicians about their desire for prognostic information. And as you can see, 87% of white parents wanted as much information as possible about prognosis, and which was almost the same as Hispanic patients, where 93% of Hispanic parents wanted as much information as possible about prognosis. So families wanted a lot of information about prognosis, regardless of ethnicity. However, when they asked physicians about which parents they thought wanted as much information as possible about prognosis, physicians thought that 57% of white parents wanted as much information about prognosis as possible, and only 34% of Hispanic patients wanted as much information as possible. And this potentially has consequences and could be related to the fact that 12% of white patients regret their initial treatment decisions, and 20% of Hispanic families regret their initial treatment decisions. I think Dr. LaWhite's study highlights that provider perceptions around race can affect care for children with cancer, and how provider perceptions, biases are contributing to Hispanic children with cancer having their therapy modified more than non-Hispanic white children needs to be explored, particularly given the potential impact on cancer survival. And of course, we do need the kids to survive from COVID. And as I previously showed, survival from COVID-19 was not guaranteed for kids with cancer. However, with 13 deaths with COVID as a contributing cause, we did not have the power to do multivariable regression analysis. But we did compare the characteristics of children who died with COVID as a contributing cause to those who are alive. So 54% of children that died due to COVID were Hispanic, compared to 49% of those who are alive. So very similar rates, and again supports that Hispanic children with cancer and COVID are not getting sicker than non-Hispanic white children. And diagnosis, with 54% of children who died due to COVID had a hematologic malignancy, compared to 68% of those who are alive. And this is despite our hypothesis that kids with hematologic malignancies would have a worse COVID course, with lower percentage of kids with hematologic malignancies in the group that died. And relapse refractory disease. 54% of children who died due to COVID had relapsed or refractory disease, compared to making up 18% of the patients who are still alive, which is what you'd expect. However, I think it's also important to look at that if 54% of children who died due to COVID had relapsed refractory disease, that means that 46% of kids with cancer and COVID who died had a new diagnosis that had not yet relapsed or refractory, supporting that idea that these deaths are not all due to cancer, but they really are. COVID is really contributing. And then non-cancer comorbidities. 69% of kids who died due to COVID had a non-cancer comorbidity, compared to 37% of those who are still alive. So again, kids who are sick going into their COVID seem to also get sick from their COVID. So what should I expect for my patient? So thinking about her, she has protective factors, including her private insurance, being non-Hispanic white, and not having relapse disease yet, fingers crossed. However, she was 18 at the time of her COVID diagnosis, so definitely older than 11, and has diabetes insipidus. So what we ended up doing with her was we delayed her scans by 1 cycle, which for her can have real consequences because she has a disease with a high risk of relapse. And if she were to relapse, I would change her chemotherapy and didn't have an opportunity to see what her disease status was on her scans. We did get her monoclonal antibody therapy. However, we also delayed her chemotherapy by 2 weeks. Although she was not admitted to the hospital, she did end up with 2 emergency room visits due to fever, but was able to not be admitted either of those times. And whether or not these were the right decisions for her, we don't yet know. So although our study gives us a good sense of what is happening with children with cancer and COVID, it of course has multiple limitations to consider. One of the biggest limitations is the lack of personal health information. In particular, that means we don't have any information about time of COVID-19 diagnosis. So we do not know how treatment has changed over time or whether or not we modify therapy for kids with cancer and COVID has been changing over time. We also don't have very robust sociodemographic information. All we have is insurance. It would have been really nice to have zip code information so we could look at things like median household income in the zip code of residence or things like neighborhood crowding, given COVID and neighborhood crowding. However, we had to balance that with the rapidity with which we could get the study open, and being able to have 84 sites enroll in 8 months probably would not have been possible if we had included personal health information. We also have a lack of data verification and really have to rely on sites to double check their data. For the longest time, we had a patient listed as diagnosed with COVID-19 in Hawaii, which really confused our Hawaii site, who had no idea who this patient could be, only for a site to realize when they went in to do the 12-week follow-up data that they had accidentally listed a patient as diagnosed in Hawaii. I think they just really wanted to be in Hawaii since we all want to be in Hawaii. And as with everything right now, it is really hard to attribute care to or symptoms to COVID-19. For example, if there's a new diagnosis patient with acute lymphoblastic leukemia who is diagnosed with COVID-19 at the time of cancer diagnosis and subsequently develops tumor lysis syndrome requiring dialysis, would they have needed dialysis if they didn't have COVID? It's hard to know. We asked clinicians entering data to enter symptoms and care that they thought was attributable to COVID-19 and just asked that people interpret our study results with that lens. And this is a lot of important data, but as with many things with COVID, it really is missing the human piece. So for instance, my patient had a father who was admitted for COVID-19 for a week, which was an added stress during an already stressful time with cancer and chemotherapy. Her parents had also come to every single appointment with her, but they could not during this time because they were both COVID positive. So instead, her sister brought her, which exposed her sister to COVID and was hard emotionally on my patient. There's also a lot of comments that come in when people fill out the surveys, and a lot of comments about children who are already admitted to the hospital every month for chemotherapy and then have additional hospitalizations because of COVID. So just an extra burden on these kids who are trying to live their lives while they have cancer. And then, of course, many kids are not the only person with COVID in their family. And there have been a number of reports of kids with cancer whose parents got COVID and died, which is not what any kid needs, but particularly not what a kid who's going through cancer chemotherapy needs. So there's a lot of stories that are important to tell that the numbers don't convey. However, this is the largest study of COVID-19 in children with cancer. Studies have previously reported on 98 children in the New York, New Jersey area and 57 children in the United Kingdom, in addition to smaller case series. There are also regional differences in demographics and public health mitigation strategies, which makes the fact that we have national data, other than the Mountain West, particularly powerful, particularly when we're looking at things like evaluating the risk for COVID-19 in children with cancer. So some of the key conclusions include that children with cancer and COVID-19 can get sick. 33% of kids were admitted to the hospital, 11% admitted to the ICU, 4% were intubated, and 2% died due to COVID-19. You may or may not remember, but early on, there were some thoughts that people who were immunosuppressed might not get as sick due to COVID because of their role that the immune system played in serious infection from COVID. However, the data has shown that that does not appear to be true in adults with cancer, and our data shows that that does not appear to be true with kids with cancer either. This data will be really important as we are counseling families about the risk of COVID-19 in their children with cancer. Also, it'll help us advise parents as they're deciding whether or not they should get vaccinated, and can help parents make decisions about whether or not their child with cancer can return to school and whether or not their siblings can return to school. It will hopefully also help guide emergency room and ICU physicians taking care of these patients and know how concerned to be when a child with COVID and cancer comes into their service. Additionally, Hispanics, publicly insured children, and those with hematologic malignancies are more likely to get COVID-19 than their peers. And in addition to helping pediatric oncology teams counsel their patients about COVID-19 risk effectively, this data may also help programs develop more targeted screening programs. And then older children and those with comorbidities are more likely to get sick, which will be invaluable to clinicians evaluating children with cancer and COVID-19 to determine if chemotherapy should be held or if they should be admitted for observation. However, even though they are not more likely to get sick, Hispanic children are more likely to have their cancer therapy changed due to COVID-19. And sensitivity analysis to determine if those delays were due to neutropenia, those protocol-driven reasons, or not, the subjective reasons, showed both protocol and subjective changes in chemotherapy. And given that Hispanic children already have worse outcomes in some childhood cancers, if COVID leads to more treatment modifications for Hispanics, COVID may worsen existing survival disparities for Hispanic children with cancer. And COVID is still pretty new, so there's a lot of things that we need to continue to work on. So we clearly need to better understand the cancer-directed treatment changes in Hispanic children. Is this due to provider bias, a history of Hispanic children with cancer having more side effects with treatment, so providers assuming they will have worse outcomes with COVID, even though it appears they do not, logistical issues during COVID, or other factors? Related, we need to monitor the survival impact of COVID-19 on children with cancer and cancer therapy modifications. I don't know whether or not delaying my patient's chemotherapy will hurt her already poor chances of long-term survival. Time will tell. We are also getting more and more emails from clinicians with second infections in their kids with cancer. We need to know whether or not kids with cancer are at higher risk of second COVID infections than the general population, and how the first and second infections may differ clinically. We also now know what COVID-19 directed treatment we are using for kids with cancer and how much we are modifying cancer-directed therapy due to COVID, but we don't know how that affects the actual course of COVID. Would my patient have been able to stay out of the hospital if we hadn't gotten her monoclonal antibody, if we haven't delayed her chemotherapy? I don't know, but we need to figure out which ones actually help and which ones we do to make us feel better. We also need to think about the vaccine. So the vaccine is here for many of us and coming for others. Given their abnormal immune systems, children with cancer may not respond the same to the COVID-19 vaccine, and we need to look at rates of COVID infection in kids with cancer after the vaccine. Additionally, going back to your pediatric oncology rotations, you may or may not remember that kids with acute lymphoblastic leukemia are treated with PEG asparaginase, and many of them have allergic reactions to PEG asparaginase. PEG asparaginase contains polyethylene glycol. And you may have read that the allergic reactions to some of the COVID-19 vaccines are thought to be due to polyethylene glycol nanoparticles. So should we be giving kids who've had allergic reactions to PEG asparaginase COVID vaccines that have polyethylene glycol nanoparticles? We'll figure it out. We also have shown that kids with cancer can get sick from COVID, and this can help us advocate for parents of children with cancer to get them prioritization for vaccines. And finally, this work came out of a Facebook conversation. And as a society, is this how we should be responding to public health crises? Or should there be national organizations that are leading these efforts? And I do want to say there is a National Cancer Institute sponsored study looking at COVID-19 in children with cancer, but they haven't released data and have had far fewer children than we do. So in terms of ability to inform care during the pandemic, have not been able to do that yet. Additionally, our group has applied to funding mechanisms, but the studies that have gotten selected have been COVID-19 treatment directed rather than registry efforts. And clearly COVID-19 treatment is important, but it is not the only important thing to examine in the face of a new public health crisis. So for each of you, I encourage you to think about your field and how the field has or has not responded to the pandemic, and what the different fields need to do to be ready for the next public health crisis. So those key conclusions included that children with cancer and COVID can get sick, that Hispanics, publicly insured, and hematologic malignancy kids are more likely to get COVID, although older children and those with comorbidities are more likely to get sick, and Hispanic children are more likely to have their therapy changed. I also want to leave you with a few pieces of food for thought. I think this shows one way that we responded to a need in our pediatric oncology community with an eye towards disparities. And identifying disparities is a first step in mitigating disparities. Additionally, I hope you've learned a little bit about COVID-19 in children with cancer, but I think it highlights the need to understand COVID-19 in subpopulations and thinking about whether or not each of you have the information you need to take care of your kids during COVID. And then finally, COVID will not be the last novel health situation that we have to adapt to. And I think this study highlights how new health situations can exacerbate or expose disparities, which are essential to address. So ending with some thank yous to the POC team, particularly Doctors Wolfson and Levine, who have been leading the effort with me, the POC consortium sites, who have really been going through IRBs and entering patient data for the good of the community, including Dr. Aftandelian. So thank you to all of our sites. My CRAs, who did not know they were joining a COVID research team, my mentor at UAB, Dr. Bhatia, and then lots of people in the Stanford Pediatrics Residency and HEMONC Fellowship Program, and especially Doctors Chamberlain and Link, who continue to give me lots of advice and support to this day and may never be done with me. So thank you so much for having me. It's an honor to talk with you, and I'm happy to take any questions.
Thanks, Emily. That was amazing. I think it's actually really neat to see the timeline that you laid out of how you had this Facebook conversation and then how quickly you guys were able to put this together and get data out there. You actually already answered, I think to some degree, one of my questions, which was, should we rethink how we do research if we can do it like this? Very amazing. But I'll move to other people's questions. So Alan Schroeder says, great presentation and incredible work filling such an important knowledge gap. Testing patterns can influence the apparent disease severity, so more widespread testing dilutes severity. Any sense of variability in testing patterns across sites?
No, it's a really good question. And clearly asymptomatic testing can increase your rates of disease, but make it look like it's less severe. That would be one of the things that would be really helpful to have date of information for. We don't collect this data, but anecdotally from our many pediatric oncology Facebook groups, early on, people were really just testing with infection, with symptoms, but now most sites seem to be having standard screening protocols. A lot of sites are testing for anybody who is admitted. And so any admissions include a screen, and others are doing testing before anybody gets imaging. So I think a lot more sites now than a year ago have pretty protocolized testing. So picking up quite a bit of asymptomatic infection. So if anything, there are quite a bit of positive screening results that are represented with this data.
Great. And then someone else is asking if any other pediatric subspecialties are doing similar research or finding similar things.
That is something I should know better than I do. Since I'm a hematologist oncologist, I know that the sickle cell community is collecting data. I think I've heard that nephrology is doing something similar, but I should know what's happening in the other subspecialties better than I do, but I do not.
I think it's okay that you're focusing on hematology, oncology, and palliative care, as well as apparently infectious disease. I have a high suspicion that this next question will be answered potentially at like an upcoming COVID talk here rather than with you, but we'll give it a shot.
Yeah.
What are the current revaccination recommendations? How long to wait after treatment for patients with solid tumor versus hematologic malignancy? How is this prioritized for pandemics, for example, H1N1 in 2009? And what might COG recommend with regard to COVID-19 vaccines given for patients over 16 who can get it now?
No, I think clearly we're going to want guidance from infectious disease doctors. And if anybody is an infectious disease doctor and wants to weigh in, I mean, in general, and again, a lot of this is going to be in a no data space. It's going to be trying to make clinical judgments for our patients. And there's been a lot of talk about these questions. We give kids on active chemotherapy the flu vaccine because they're at risk of getting sick from the flu. And what our thought has been is that this data supports giving kids who are getting active cancer treatment the vaccine. 2% risk of death is real, 4% risk of intubation. Those are pretty serious numbers. So the thought is that this supports the idea of giving kids on active treatment the COVID vaccine. And I think there's a handful of places that are giving I know of places that are giving COVID vaccine to adults on active treatment for cancer. And clearly because of age issues, that's not happening as much in the pediatric oncology community, but I think this data supports that. But whether or not in terms of efficacy and do they need to be revaccinated after they finish treatment, all of that, I think time will tell.
Great. And then Melissa Mavers, who's one of our transplant faculty, asks, any effect on COVID severity in kids who recently received pegasparaginase versus those who didn't? I'm wondering about the coagulation effects.
Oh, that's a really interesting question that we have not yet looked at. We definitely have data on whether or not they got pegasparaginase recently, and we know whether or not they got clots from their COVID and whether or not they got sicker. So interesting question. Do they have more microthrombi and all of that? But
and then were there any infant cancer participants in your study? Was the sample sufficient to have conclusions about that population?
Another really good question. We do have kids less than 1 who had cancer and COVID-19. Our numbers are going to be small enough that we can't really draw any conclusions, but unfortunately our numbers keep going up. So, give us another 6 months. But yes, we did have kids less than 1. And I know that at least one of our deaths was in a child less than
1. Another great question. Have HIPAA regulations prevented you from evaluating data that you would be useful for treatment decisions? If so, do you have any suggestions to mitigate those?
I think it's an interesting question. And I think the biggest challenge with making treatment decisions based on this is that this is all observational information so we don't have causation information. Do those changes in cancer-directed therapy change the course of COVID? We don't know. And I think that's the biggest limitation. The other big limitation is we get a lot of emails from people who want particularly more information about the kids who died. And that's the big more IRB limitation in terms of we're not able to report information on small sample sizes of people who died. So there's a lot of information that we have about the kids that died that we cannot share because of IRB regulations. And I think that is some of the information the community really wants.
I wonder, Emily, I mean, I think you guys put this together so quickly, which was great, but as you said, you had to leave out a lot of information that people want in order to get it moving quickly. I'm guessing a lot of the sites have information saved where they have linked their like ID that they've entered to the patients, and that maybe, you know, when things calm down a bit and we all have lots of free time, we can do, you know, a more IRB heavy investigation where we could actually get more of that data. Just
that's a really nice idea. I mean, even if we could just get zip code, it would make such a big difference. Yeah. So Catherine, are you promising that you'll get that IRB through for Stanford for me if we
yes, I'm an IRB master. Oh yeah, central IRB. Okay, so Sean Green, one of our awesome pharmacists, says, could the higher prevalence of pharmacogenomic alterations in Hispanic patients, so more likely to have TPMT or NUNT deficiency, and thus the higher risk of neutropenia or infection, contribute to the bias toward modifying their cancer therapy?
Yeah, and I think, hi Sean, I think that is exactly one of the things that I kind of expected, that when we did that sub-analysis of whether or not the cancer-directed therapy changes were due to neutropenia or other reasons, I expected that the most of the cancer-directed therapy changes in Hispanic children was going to be driven by neutropenia. And that was clearly a piece of it, potentially due to those genomic changes that you mentioned, but that was not all of the changes. So I think that is definitely a piece of the puzzle, but not all of it. I also think that wonder about oncologists who have been trained and see Hispanic kids getting more neutropenia with treatment because of those issues, and more issues with liver enzyme issues. And so are we as a community more gun shy with intense treatment for Hispanics? I don't know, but I wonder if the history of those genomic modifications making treatment harder for Hispanics then affects areas that it doesn't necessarily need to.
We're almost out of time. I'm going to skip a little bit. Stephanie Smith says, fantastic talk and research. Thank you, Emily. You mentioned that this effort has been limited to children within 1 year of receiving cancer-directed therapy. Does your group have any plans to expand this to include the longer-term pediatric cancer survivorship population as well?
We could do so much. Yeah, I think it's a really important population to be looking at, particularly given the role of comorbidities in severe COVID infection. And, I think as everybody remembers from the pediatric oncology rotation, heart failure and all kinds of other comorbidities and renal disease comes with cancer treatment. So probably a group that really is at risk of getting worse COVID. That's currently not on our plan. Our next big lift for modifications is to actually try and capture that vaccine information. So I think our vaccine will be our next big modification, but maybe in a few months, we'll be ready to take on cancer long-term survivors. I think the other issue is access to our populations, and that it's nice that the pediatric oncologists know what's happening to their kids. But once you get into the long-term survivors, they're not necessarily in oncology clinic every week. So a little bit, you're going to probably end up with more selection bias in terms of who you're capturing, but something now thinking through this, Stephanie. So thank you for the food for thought. So.
Okay, we are at 9 o'clock, so I'm going to end it, although I know that there are more questions. I'm sure if people want to reach out to Emily directly, that we can get you her email.
Definitely.
And thank you so much for that. This was, it's just amazing to see how you guys put this together so quickly and are answering this information that's just so helpful for all of our patients. It sounds like a lot of people in other fields are maybe thinking about doing it in their field as well. So that would be amazing.
And feel free to reach out as you're figuring out struggles with that. So happy to.
Thanks everyone so much for participating. Thank you, Emily. Great to see you.
Thank you, Emily.
Thank you, everyone.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.